thank you all for joining us. We just heard your amazing story, so I'm going to start off with you. Would you please introduce yourself to the audience and give us a little background about your thoughts on what you're doing, and we'll go down.
Okay, thanks.
Thank you.
My name's Shannon Phillips. I am first a provider of care. I'm a pediatrician, a pediatric hospitalist at Cleveland Clinic in our children's hospital, and I'm the quality and patient safety officer. And I think the space I spend time in is a couple. One, becoming every day a more highly reliable organization, giving the care we want to give every day the way we want to. We spend time learning from the things that go wrong, and when they do, being honest and forthright, and not just learning and making the systems better, but making sure we heal the patient, their family, and the caregivers involved. And then I'd say another big piece of the work is around culture, and I'm one of the leaders that's a steward of that and nurturing that. And I think probably when we talk about assertiveness and speaking up, all of us, we've had a little time together, we'll talk about how important that is, and that journey's not done. So thanks for inviting me.
Thank you for being with us, Shannon.
Good afternoon. I'm Nancy Myers. I work for the Summa Health System, which is headquartered in Akron, Ohio, just a little south of Shannon, and have had the privilege over the last 4 years of helping to lead and facilitate the implementation of high reliability concepts across our system of hospitals and ambulatory providers. And cannot say enough about our very first safety behavior and how many patients we've saved by it, which is to basically speak up. We call it practice with a questioning attitude. And it's not about being obnoxious and asking a bunch of questions, but really we talk about it in terms of it's having your coworkers back. You know, you're raising an issue to stop them from maybe doing something that's going to harm the patient, but also is going to be devastating to them. And so that's how we've really tried to talk about speaking up and the importance of it. It's obviously critical that we're speaking up on behalf of our patients, but we're really speaking up to support each other as well, and that's equally as critical. So thank you.
Hi, I'm Cindy Cassity. I'm the manager of patient safety at Baylor University Medical Center at Dallas, part of the Baylor Scott and White Health System, about a year and a half now. Do lots of different things. I kind of consider myself a project manager. I have oversight of two of our biggest projects are over-sedation and suicide prevention, but work very closely with the quality department and risk department. We do a lot of teaching. I work very closely with a physician, Dr. Bill Sutker, who is our patient safety officer. And together we do a lot of team training. And this, you know, we do a lot of training about critical language, assertiveness, teaching them patient safety, scripting, SBAR, stop the line, CUS is in team steps, for those of you who know team steps. But I think the important piece that I haven't heard us talk about yet in the last couple of days that I'm hoping we could talk a little bit more about, because you could teach everybody and they could be completely pumped up by the time you're done teaching them for 2 days on team training and how we communicate and teamwork, but really there has to be a psychological safety. And that is not something that you can teach. That's something that, based on what I've learned, really comes from leadership. And because teamwork and communication is important, but you have to have leadership that ensures that you have that psychological safety. Flattening hierarchy is what we heard Julia say this morning. And well, how do you do that? I mean, you know, that's something that's been around forever in healthcare. So it really takes leadership. That's first and foremost. And luckily, I have a lot of good leaders at Baylor. So I hope we can talk a little bit about that.
David.
Hi, Joe, and good afternoon. My name's Dave Mayer. I oversee quality and safety at MedStar Health, which is a large integrated health system in the Maryland and DC areas. It's got 10 hospitals, over 300 non-acute arenas or facilities, and so keeps me pretty busy. I will say, Joe, first, I wanted to thank you for your leadership and for your vision to see where this program has come in 3 short years, and the recognition of this driving to zero preventable harm by 2020, and to see people like Vice President Biden and former President Clinton back again, huge accomplishment, so thank you for that. You'll hear my comments today really focus in on the thoughts that we've built a culture out there over the last 30 years that is very challenging now to take down. It's not impossible, and there's a lot of great work going on, but it's going to take a lot of work to reverse the culture that we've put in place and rewarded people technically for through the years. My comments during this session will be focused mostly on three areas. One is resilience science, and we talked about high reliability and where we've gone at MedStar and the high reliability journey. The second is on human factors and human factors engineering. A few people have touched on it this session. If we don't figure out factor science and incorporate it and protect our caregivers and our patients so they can provide the optimal care that they're trying to, we'll never get to zero. And then finally, the patient partnership, which many of you know has always been big in my realm, in my world. People have heard me say this, I have learned more about safety and quality from patients and family members than I have from my colleagues through the years, and that has changed programs we've done, that's made a lot of our work become more effective. So those will be the areas I'd like to touch on today around assertiveness.
Thank you. Well, Karen, thank you for the amazing introduction.
Thank you.
And thank you for asking everyone to bring a friend next year, a colleague across the line. That's what it's going to take. Yeah. You, unfortunately, have seen unsuccessfully articulate people like yourselves ask for help, ask for something to change in the course of the care of your loved ones, and unfortunately, they didn't quite work out well. What can you teach us from that experience? What can you teach the audience of how you could have done it better? And then also you said something really important, teaching clinicians how to listen better. But would you please get into a little bit more detail for us?
You know, of course, I ask myself that question all the time. How could we have been better prepared? And we went into the hospital with absolutely no other feelings except extreme gratitude and relief that Dad had been eligible for a lung transplant to cure a really horrible disease. And unlike everything else in life in which we prepare, I don't know about you, but any of you who have had a baby, you probably read the book, What to Expect That You're Not Expecting. I know for me, it was my Bible. I read it every day through every pregnancy. And there's nothing like that for patients and their families. And frankly, so actually I ended up writing a book, the sort of What to Expect That You're Not Expecting, you know, only for hospital care, you know, with all these checklists. And it does not fly off the shelves because no one wants to think about having a baby is really fun. You might be anxious about it, but it's really fun. It's a great, joyful thing. Thinking about hospital care is not. No one wants to think about it. So I don't know what there would have been to help us prepare then, which is why I'm so determined that we're all prepared now. And it's the only way I can actually live with myself. So.
I mean, being in this space, some of us have been in it for 10 years, some maybe would be 26 years. It's taken me a long time to learn a language.
Yeah.
I hear Dr. Rich Cremona talking about healthcare literacy. We had, I'm drawing a blank, but we had a doctor from Germany, born in Belgium. Where is he? Hugo, thank you, Hugo, where he was talking about teaching kids at a young age how to do resuscitation. And someone, I think Lenore wrote on the blog yesterday on our app that maybe we ought to be teaching kids not just resuscitation when they're in the 5th or 6th or 7th or 8th grade, but maybe about the 10 things that can go wrong in a hospital if they're ever going to the hospital for their family or themselves, what to ask, what to be worried about. What are your thoughts about that? We have, by the way, we have someone here as a board of trustees of a hospital that is also involved with the education, and we're going to maybe try to get public education involved.
Brownie badges.
Yeah. What do you think? I mean, they're sitting there learning
Eagle
math,
Scout projects. Yeah.
learning English, learning biology. Why not teach them that one moment in life, the moment of truth, of how to better be prepared to what to ask. What's your thoughts?
So I have a thought on that. So I think that's a great idea. I think, though, that it's part of a much bigger conversation. Most of us will never be in the hospital, or if we are, it likely will be very unexpected and for a very short period of time.
Yeah.
So I think that the larger conversation that this is housed in is how do we be better healthcare consumers and develop a better relationship with our healthcare providers over the course of our lives, not just during that acute stay, because you need to have a sense of trust and familiarity with the healthcare system, and most of us experience that throughout our lives as we interact with our primary care provider, our kids' pediatrician. So I think the idea of assertiveness is larger than being assertive for that brief period of time when you or a loved one might be in the hospital, and really is part of a larger conversation about how do we become more active and engaged and a better partner in our healthcare overall, and then specifically for those periods of time when you are in that kind of specialty care situation, whether it's in the hospital or maybe you're receiving home care or you're in a skilled nursing facility. There are some then specific tips of particular areas that you might want to be heightened or have a heightened sense of awareness around or be more assertive around. But I think you've got to start with children too, of not putting healthcare providers up on a pedestal, but really starting to teach ourselves and our kids, and to the extent we can, our elderly parents, how to be just better consumers and partners in our healthcare overall. So,
any other thoughts?
Well, I think it's a little bit of, we are a country where healthcare for years has been done to us. So if you think about being a patient, even in primary care, but particularly in the hospital, it's been about what people do to me. And what I think we're talking about here is talking about doing this with you, with me as the patient. What does it look like to do that, whether you're well or ill? And I think your point's well taken. If we don't take that on when things are going well and say, I'm in this with my provider, we're a team, we're keeping me healthy. When things turn bad, when you're in a different place, you don't even have the skills, you haven't practiced the skills to interact with us differently. That's the patient side. I guess I don't want to sell short the fact that we absolutely, as providers, have a lot to learn. And David, we've engineered into doctors, stuff everything into your head, be able to do it all by yourself. If you're not perfect, you're a failure, and you have to be perfect alone. And we have to engineer that out of the system. So patients need some maturing. We definitely need some maturing. But I think that concept of it's with me, not to me, is important, whether you're well or sick.
Shannon, I don't know if Cleveland has a lot of tornadoes, but for a while I finished my elementary school and junior high in Alabama, where we had tornadoes, and we had tornado drills all the time.
Right.
Mm-hmm. Do we have hospital drills where we teach our kids how to be ready for that?
No.
No?
I mean, the short answer, no. And, thankfully, and I think you said that well, most kids are going to stay out of the hospital. Most families, until you are older, are away from this. And, the practice is, do you feel comfortable talking to patients? Does a kid feel comfortable talking to their doctor? That's a great start of with and decision-making together about your care. Great place to start. It's really a vulnerable time. The gift of being a healthcare professional is you get somebody's very sick and desperate and shows up in our hospital, and they have put the privilege of their trust of their lives in our hands. And it is such a wonderful calling and opportunity. But we have to step up. We're not done. We do not do this well enough. We do things to people. We need to do them with the patient. And there's a lot to do. I don't know how you drill for it. I don't know if anybody has ideas, but the conversation is important to have because then people will treat it differently.
Cindy, what have you done at Baylor to teach the patients that are coming in to be more assertive? And then, how about your clinicians to listen to it?
Well, so a couple things. We also have oversight of our Patient Family Advisory Council, and so the first thing that anyone here can do is start an advisory council. So I don't know why, but in healthcare, we assume we know what's best for our patients. It's kind of always been that way. And I know a lot of the conversation is around, I used to work in transplant, so it was always around the wall chart. And here's this patient in bed with spouse next to him. And some of the patients would say, I don't even know if they know what I look like, because all they do is go look at my wall chart here. So I think, again, it's really, it's getting our patients and families involved, either through an advisory council, sharing stories. Most providers want to make a connection with their patients and with the patients' families, and that's why we came into healthcare. So sharing stories is a very powerful way to really reach out to the heart of the clinician, the heart of the healthcare provider. So sharing stories would be one. Again, it's not hard to start an advisory council, just start it. I mean, it doesn't have to be perfect from the very beginning. We didn't have any of an advisory council at the entire Baylor healthcare system, and the physician and I that worked together were like, let's just start it. Let's just start it. We had to get legal approval, all that kind of thing. But recruiting, and then just, they need to be at the table at every single decision that we make. Since then, they now sit on major committees, medication management committees. They're involved with process improvement. They're involved with construction. But Texas is still kind of far behind. I know there's some healthcare industries that have been doing that for 30 years. They hire their employees. They hire the physicians. So we're moving slowly, but just making sure that we still are listening and that they're at the table of this conversation, exactly what we're doing here now. But then as far as provider, because it's kind of a different thing, but I would say it's different but the same. As far as what the provider wants is the same thing as what the patient and family wants. It's three things. They want to be trusted, they want to be respected, and they want to be listened to. It's the same three things. That's all that we want. Every single person here, it doesn't matter what you do. We want the same three basic elements. So it's really just, again, reminding each other that have to talk to each other, teamwork and communication, but again, the leadership has to set the tone. They have to say this is an expectation. They have to treat every single team member in the hospital as an equal. That's one way of getting to where there's not this hierarchy, and I feel safe speaking up, even though that might be the chief of anesthesiology, and he's very well respected, Dr. Ramsey in the room, but I still can speak up, and I know I can speak up with Dr. Ramsey, and he would welcome that. So another thing is recognition, recognizing employees for speaking up. That's something that we started. When I first started patient safety 8 years ago, I looked at all the reported good catches and stop the line events, and there was 49 for the entire year. This is just good catches, not other things. And so Dr. Sutker and I created something called the Fab 50. We just rounded up. We were like, we can't have 49. We got to have at least 50. So the Fab 50 or Fabulous 50, where we recognize 50 employees who reported good catches and stopped the line events. So that was 8 years ago, 10 ceremonies ago. Just celebrated our 10th ceremony. We called it the Fab 500. And we had to pick from 401 reports. So we have made some progress, and the ceremony itself is kind of fun. Our president or COO puts on a jacket. They have a fleece jacket that we've customized, and it has a little sticker that says Team Up for Patient Safety, and they walk across the stage, and our Vice President of Medical Affairs and Chief Nursing Officer gives them a certificate. I see them as my patient safety champions and include them as much as I can in all the process improvement projects that we do. Again, something easy, something relatively inexpensive. Doesn't have to be a jacket, but just recognizing them so that they see that leadership appreciates them reporting. And then also we got to make sure we do something with those reports. So it's speaking up, but also reporting so we can make changes, process improvement.
I'm going to shake things up a bit here. Okay. I've visited a lot of hospitals in my work all over the world. And I also, unfortunately, one of our board members who was a great inventor and a doctor, Dr. Jeremy Swan. Yeah. I saw how this amazing guy that people used to get his autograph when we'd have meetings, get the stroke, not get the right care, kind of be made small and not dignified. And I moved them from that hospital to another one immediately. I have to say, and I've had my own experience with having children and babies and seeing how the nurses and the doctors behave. And I hope I'm not giving too much credit, but not putting the spot too much. But I'll tell you, there was one institution I went to, Vermont, known as Fletcher Allen, now Vermont Health Network, where I felt a different level of collegialness, of focus on patients than I'd seen any other place. And I know a lot of close friends, and they get calloused, people who don't take care of themselves, gangs. How do we make the nurses and doctors not get calloused? How do we get them to care? I mean, David, you guys have some amazing initiatives where in your hospital, you're apologizing within half an hour when someone gets hurt. Please, what do we do?
Well, and first I want to clarify something. I think, in my experience, in looking at air events and harm, these are the vast 99.9% of the people who are providing care don't go to work every day thinking they're going to harm somebody. They're trying to do the best jobs they can, and it's why I made a point of stressing human factors, and we won't get to zero until we start working with engineers consistently and understanding systems and processes. These are good people who come to work and get put into systems that are just not right. We've created this over 20, 30 years, and now we've got to look at other high-risk industries, other resilient industries that have proven that they could go to zero harm, that they could prevent defects as best they can. We've got to protect our people more, and at MedStar we've been on a close to 3-year journey on resilience and high reliability. We trained close to 30,000 employees on the tools and techniques, behaviors, and accountabilities of resilience science. We had transporters and parking attendants sitting with our board of directors together at teams discussing how we were going to make our system safer. We need to embrace more of that, Joe, because there's too much burnout in our specialty. There are too many, care for the caregivers. We've got an active care for the caregiver program because people are just devastated when these events happen to them. And you look at it, and we all know that people in this room, it's not one person or one event that led up to it. You can literally walk through the process, and when you do effective event review, you find out there are so many causal factors. I think in healthcare, we have looked to ourselves to figure out the term root cause analysis, and I will tell you, we did a deep study of the literature as well as our work at MedStar before I came there, and 85% of the root cause analysis that are done come to the conclusion about repolicy, retrain, re-educate, remediate, and when you look at resilience science, those are things that will never sustain. They're good for 3 months, maybe 6 months, but if you want to create lasting change, like the deck of an aircraft carrier, like nuclear energy and like aviation, and I understand we're different, healthcare has got unique curves to them, but there are tools and techniques and behaviors that if we adopt, you could start seeing change and putting our people in the right position to provide the care that they're trying to. So, I think, I've become, as was said yesterday, a tremendous believer in the resilience science. We've seen our serious safety events across our system go down by 52% in 16 months. And that's in an organization that has also embraced transparency and is reporting more of these events to us for learning opportunities and a way to do effective event review and really make changes to the system.
Well, yesterday we heard the Deputy Director of CDC, I think it was him, who mentioned a 3 Michelin, 3-star. Wasn't it him? Yeah. Right. And I feel like, that's what we need. We need 5-star hospitals, right? Would you please tell the audience about what MedStar is doing, both on the quick to apologize, on not charging for care that was gone wrong, and then tell us how has that gone? I know it's a little off track, but I think I think, going back to what you were saying, that it takes the leadership to create that culture. I want to get back to that.
And a lot of that work really started when I was at University of Illinois with a program that a team of us went after called the 7 Pillars, which has now led to a national initiative with the American Hospital Association and AHRQ called Candor. And I loved your use of the word candor. And it's communication and optimal resolution. So we look at and we take the approach that whenever a serious unanticipated outcome occurs, care goes in a direction that we had not anticipated or our families had not anticipated, we needed to start a dialogue. We needed to start a conversation to figure out why that care went to. And when I was at Illinois, we had about 400 of those unanticipated outcomes. We found that 76 of them were because of bad care. The others were just good people doing great care. But if we hadn't started the conversation early with the patient and family and used empathy first and said, we don't know what happened, but we're going to get on top of this and we're going to figure it out and we're going to keep you in the conversation and answer your questions as best as we can. Once we knew, and sometimes you know right away, I mean, the people in this room know that, sometimes you know within minutes that this was, an error that was a breach in care. Sometimes it could take weeks to figure that out. You need an autopsy, you got to bring in outside opinions. But the moment we knew that our care had breached, empathy went to empathy with apology, and then was rapid remediation and support. Going to MedStar has allowed us to do things that we couldn't do at that program in Illinois, and that's immediate support for the family. If a patient has to be kept in a hospital an extra 3-4 days because of something that happened that we're not sure, hotel rooms, the acute needs of that family, we could start addressing as a health system because we look at it in Maryland and DC that we serve our communities. And when our communities have these events, we need to step up in the acute side. But then as we work through the process of learning what happened, if we did wrong, then we get into how do we do, as Rosemary Gibson says, benevolent gestures. What is the right way to bring this? And we really believe that these communication and optimal resolution programs make a tremendous difference because they allow us to be open and share things so we can learn from them. But more importantly, I've heard a lot of times people say, if you think families want to go through 4 or 5 years of hell reliving these cases because they think there's some lottery ticket or a reward at the end, they want to bring closure to it. If you think caregivers want to sit and listen to expert witnesses and depositions and go through 4 to 6 years, they want closure and support, and that's where care for the caregivers is such an important element of the work we do. We're able to get these cases settled within 3 to sometimes 7 months at length versus 4 to 6 years sometimes, and bring closure to them. Many times patients and families don't want to see us again. They say, I never want to see your program again. But I think when we do it the right way after harm has occurred, we learn better, we can maintain some trust, and we've had great opportunities where patients and families have become part of our consuls, become part of our advisory committees because they want to give back to the hospital. It's a part of healthcare that I think we haven't done right for many years in supporting our communities and supporting our care teams.
That's bravo. I mean, and would you share some of the financial benefits of what you've done too, please?
Well, yeah, we've seen them at MedStar too, and MedStar was doing a lot of this work, but we've just raised the level through the Candor project with AHRQ, and that we're one of 8 of our hospitals are creating the toolkit to be launched across the American Hospital Association's hospitals. At Illinois, we saw savings over a 4-year period of about $40 million in medical malpractice drops, and our excess amount of money had gone up to like 84 million. We were putting on reserves every year, dropped into the 40 million range. And the amount of money you save in legal fees and administration costs for having to work through 4 or 5 years of cases and closing them in 3 to 6 months. And I'll tell you that, people say, oh, the plaintiff's attorneys, plaintiff's attorneys, the majority of them want to do right for their patient, 95% plus. If we could bring closure to that event and learn from it and move on, they're fine with it, and they don't want to go to court, nor do the families. We found, and Boothman found this too, Rick Boothman found this at Michigan, it was our own defense attorneys who said, you know, I'm going to get my expert witness, and I'm going to do all the, no, said, no, we've already admitted fault. We've already said we were bad, our care was bad. We just need you to come in and figure out a model that works for the remedy with their attorneys. And many of them would say, well, that could take 2-3 hours. We go, yeah, it could. We ended up having to pay them $10,000 minimum just, you know, because they wouldn't take the case. So it was, we would guarantee them, if it takes you an hour, you get 10 grand. If it takes 4 hours to come to resolution, you get 10 grand. But if we disagree, if we agree to disagree, then we'll play the traditional models and stuff. So it was a win-win-win for everybody.
That's great. That's great. Nancy, tell us about this creative program you've created at SUMA.
Excuse me?
The creative program you've created at
So
SUMA.
we've done something similar to what MedStar has, and we also, with input from our frontline staff, clinical and non-clinical, and I think that's an important piece. It's every staff member at the hospital has a piece in this, not just clinical staff. We came together, we looked at our own cases of harm over the prior 2 years from where we were starting from, and figured out what were the fundamental reasons across all of the serious harm that we were causing that were leading to that harm. So, and not surprisingly, communication issues and that failure to speak up was a critical piece. And it's not that people don't want to speak up. It's that I think that oftentimes, you know, we all question whether we're really an expert in the situation. So it's very typical, I think, in healthcare when you have a root cause analysis to hear folks say, I thought something was wrong, but I wasn't sure. Mm-hmm. So I didn't say anything because I figured that that person knew what he or she was doing. So a lot of the training that we did with our 11,000 associates across our system was really focused on trusting yourself and listening. We called it listening to your internal smoke alarm. When your smoke alarm was going off, respond to it. 99 times out of 100, it's probably a false alarm, but that's okay, and we'll support you in that. But, you know, speak up and stop the line. And so we did that training and then put into place safety coaches and had leadership and continue to have leaders out rounding, talking to staff routinely and encouraging these types of behaviors. And we too, in the last 3 years, have brought down our rate of serious harm to patients by over 80% during that time frame. And one of my favorite stories about speaking up was one of our environmental service workers, one of our workers who comes in and cleans your room every day, was in a patient room, this was about a year ago, had seen this patient for a few days because the gentleman had been in the hospital with some lung issues, and engaged him in conversation as he had in the prior couple of days, and just noticed that something just wasn't right. He just wasn't talking like he had been with them, and he just didn't seem right. The gentleman, our worker, had no idea why that would be, but because he'd had the training, and he told us this, he didn't just let it go. He went, found the gentleman's nurse who came in and did a quick assessment, and they called a rapid response team because he was actually in the beginning stages of respiratory failure, and we were able to intervene and rescue him because we had someone who spoke up. You know, so those stories just warm my heart every day. I think warm our heart in healthcare. Mm-hmm. So that's what we've been doing over the course of the last few years, and continue to develop interventions around with our staff.
Listening to their smoke alarm. So let's talk about that.
Yeah.
How do we get clinicians? And we'll go around, I know we're running out of time. Starting with Shannon, how do we get clinicians to be more assertive? And what I'm asking about is, I'm not just talking about, you know, bringing the line down, which I think is a great concept. For those, you know, in manufacturing, anyone who thinks there's a problem, a defect going into the product can bring the line down, not just the supervisor, the assembly line, anyone. But how do we get clinicians to realize, whether they're at work 12 hours a day or 6 hours a day, to listen to their training, listen to what they know is best for patients, and assert themselves and go as high as they need to go in the hospital to do, I heard that word cuss from,
Yeah, cussing. I think all of
yes.
us use that as a term.
yeah, it's wonderful. How do you ring that safety bell when it comes to, maybe it's the only way to get attention, throwing down that race card, how do we do that?
It's funny you just said race car. I think we in healthcare have to act more like pit crews. Atul Gawande did a great art piece, if you haven't seen it, in the New Yorker, I think it was, forgive me if it wasn't, but where he described the fact that, we tend to be chiefs and Indians. I'm the doctor, you're everybody else who's going to help me. And the fact is that healthcare is not like that anymore. It's so complex, and we more need to be a pit crew, level the field, make everybody feel like they have a voice. But easier said than done. What really helped us, I would say more than anything, is to have very clear escalation guidelines. So when it gets practical and you say, well, he or she is more important than me, or I'm intimidated, you had other places to go. So we have had events, and I reflect on the situation Karen shared and others, where you have to be able to know where you can go next. So for example, from a patient side, allowing patients to pull the cord and execute a rapid response team is a huge benefit, so that people come to the bed and just with a different side of eyes look. But providers or healthcare professionals need the same thing. Whether you're a resident, a nurse, a nursing student, whoever, is to know clearly how to escalate. And for example, in our children's hospital, literally on every floor is a map that tells you what to do. And it doesn't say, gee, if you're a nurse, you call your assistant nurse manager and then this and then that. It shows everybody how they can get to the chair of the children's hospital. And it doesn't matter from what place you come, and everyone is allowed to use it. And that's really important, I think. And what was great is when it got used once and the chair got called, and he was actually in another country, and he answered the phone, and he said, tell me what's up, and answered, thanked the person for calling, picked up the phone, took care of the problem. And that literally in a moment changed everybody's understanding of what it meant to speak up. Because it just flat out didn't matter who you were or what the question is, how mundane it might be, or was it wrong, didn't matter, it just got handled. So I think escalation is a really effective tool.
So teaching and then by example showing that you listen. Mm-hmm. Nancy?
I think the other thing that, in addition to that, I would add is what we've tried to do is just make asking each other or cross-checking each other a common part of our language. So it's not something that we only pull out in situations where we are really concerned that something bad is about to happen. It's rather literally part of our day-to-day language that we use with each other. So when I'm walking through hallways, or even in my own office, I'm not working in a clinical setting, but I have clinical folks reporting to me, I routinely hear people throughout the day saying to each other, hey, can I ask you a clarifying question? Which is one of the things that we've taught them to use that phrasing. And again, so it's just part of the natural way that we communicate around non-critical issues, so that it's very easy to use that same language. It's very natural to react in that way when it's a safety critical issue in front of you as well. So having that common language that we just expect to hear and use routinely in our day-to-day operations as we're cross-checking each other. And I also routinely hear people say, hey, thanks for the cross-check, which is something that is part of our new culture of safety language. I think that's really important, so that it's not something unusual or different that you're doing in a critical situation. It's just part of how you operate.
Thank you. Cindy?
I think practicing. So again, it's one thing to teach staff, and we do a lot of education with our new nurses and new physicians with stop the line, SVAR, briefing, debriefing, huddles, all those things. But when you listen to what you're saying, you're like, oh yeah, I get that. That's so common sense. Why are you even teaching me that? You really have to practice it. We do a lot of exercises in our team training. I know we also use it in our simulation labs, and that's something that we haven't talked about, but simulation is pretty powerful. You can simulate real events that happen so that staff can kind of connect the dots and understand, oh, maybe if I implemented stop the line here, harm wouldn't have caused, or wouldn't have reached the patient. So I think practicing is really important after education. In Team Steps, we learn about coaching and having one coach for every maybe 10 employees, so that you have point of care coaching on site, so that again, someone that can really mentor you and encourage you, hey, you did a good job with that huddle, or hey, maybe let's practice some S-bar, here's a worksheet, let's go over a few examples and let's practice with each other. So I think practice is pretty powerful.
Thank you. David?
All great stuff. I'm going to go in a little different direction and get back to human factors and science and creating within your environment the feeling that the environment is safe for people to talk about things because of processes and system reviews. James Reasons, the father of air science, said we can't change the human condition, but we can change the condition under which humans work. And we believe in that. Somebody yesterday said, even the best of physicians will make errors at times. I'll say even the best of physicians make errors every day, but we catch things. How many times do we send an email without the attachment and then have to reascend it? There was a study that came out just about 8 months ago that said pilots make 1 error per hour in the cockpit while flying your plane. Yet today, just 6 months ago, they came out and said aviation is safer than it's ever been since the invention of the jet engine. So the idea of we could fix people by telling them to be more careful, pay more attention, it doesn't work. I mean, so you've got to really bring in factors, scientists, to look at things, to understand why that decision made sense to somebody. Because if it made sense to them, as Sidney Decker says, it will make sense to somebody else. And I'm very blessed, and I think you know this, that we have a National Center for Human Factors Engineers. We have 16 human factors engineers sitting around the table with our safety teams, our innovation teams, our researchers, and not only looking at the tertiary events that have reached the patient, but now how are we looking at secondary and primary events that haven't yet reached the patient, and trying to design our systems so they're safer. I've just become a big believer, if we're going to get to zero, we need to embrace factor science.
Thank you, David. Yeah, the technology and
process.
And
plus it makes our, when people know, and I think a number of people came up to me and said, thank you for Annie's story. It was a video we created about how we did it wrong and how we learned through factor science to do it right. It was a nurse who had read a glucometer wrong. And the first reaction of one of our hospitals was to suspend the nurse because the patient had a serious safety event from that. We brought in the human factors team and said, wait a minute, and showed that these devices were built to fail somebody. And if it didn't happen to Annie, it would have happened to somebody else. And we changed the glucometers at 7 of our hospitals within a week after getting our human factors, and protected our future people who would have had the same event happen to them.
Thank you. Thank you. Karen, in the story of the breakfast that was said yesterday with the chicken and eggs and the pig and the bacon, the rest of us are the chicken and eggs here, and unfortunately, you're the committed ones with the pig and the bacon. We're sorry you went through that tragedy, but we're happy you're part of our team to end all tragedies. What's your take? How do we teach clinicians to be assertive when it comes to safety?
That's a hard one. I'm on the outside looking in, obviously having been a participant. And they're all addressing the cultural changes that need to take effect in order for clinicians to feel safe. And I think that's, a fundamental thing. Everyone needs to feel safe. They can speak up at wherever. I think for patients and families, we share that. It's always hard. You don't want to ever feel like you're second guessing a provider. And people do feel at risk too. Oh, if I speak up, maybe I will annoy someone who is taking care of my loved one, and then there will be retribution. So you want to be very careful about how you speak up and what you say, and it's very, very intimidating. I think the rapid response team is about the greatest thing that was ever invented. And I know from studies it's not being used frivolously. When they are used, it's for very good reasons. I think there are ways to reach out to patients and families to be able to know who the other people are that they might be able to call in for assistance before you get to a rapid response team. It is really overwhelming to go into a hospital and see a sea of scrubs and different colored jackets, and you don't know the roles that people play. You don't know, who's a student and who's an intern and a resident, and what is the role of a resident versus an intern versus your doctor? We just don't have an org chart, really, and that would be really nice to know who's who, what they do, what their roles are, and who, sort of who the backups are for those people, who you can go to if you have a smoke alarm going off in your own brain and you just want, that little reality check to know that there's someone else that you can go to. Although I have to say, and I don't know how you handle it, but, I think culturally, we never want to be that person who does like an end run. You know what I mean? There's something that's not okay about, it's also known as going behind someone's back, or, so how do you navigate that too? I think it all has to come from permission, really, from the care providers, is that we understand there are some times when you may want some additional information. You might want a reality check. You might have a gut feeling about something and you might not feel like you're being heard. It's perfectly okay. And here's who you would go to, how you get in touch with them, and it's okay. The permission has to come from all of you. And I think it's a really simple thing to accomplish, but your cultures have to be prepared for it. And I think these are great ideas that you've shared.
Karen, you mentioned the Rapid Response Team Act. What a wonderful thing that is. How many of you in your hospitals allow patients' families to make that call? Wow, that's fantastic.
Yeah.
How about those in the hospitals? Look at that. That's great. It's wonderful. Well, we're out of time. I wish we weren't, because this is such a wonderful group. But thank you so much all for coming. We're going to do the heavy lifting of turning this patient and clinician assertiveness into a tool that others can use in the breakout session, that hopefully when someone's going to a hospital, they can Google, what do I do when I go to the hospital? And maybe these things pop up and help them. Thank you all so much for your time.
Okay, thank you. Thank you.